Thank you so much. Here, Dr. Alka Tajli, Principal of Fiber Nursing College from India. Now I'm starting my study on a neonatology. I'm doing a slide here.
Good morning, everyone. My statement of problem is a study to assess the effectiveness of nesting on biophysiological parameters and sucking response among low birth weight babies at selected hospitals, Surat, Gujarat. Sorry for the disturbance. Introduction. Newborns are the most vulnerable group in getting adjusted to the new environment. Following the birth, the first few months will be act as a transitional period for during the baby adjusts from the aquatic to the aerial environment. Therefore, care methods that facilitate the better adaptation of the neonates will early postnatal environment has an important role in growth of the newborns. So birth weight is one of the most accessible and most misunderstood variable in the epidemiology, as weight at the birth is strongly associated with the mortality risk during the first year and later with the development problems in a childhood. According about the birth weight, according to WHO, low birth weight is defined as a newborn birth weight is less than 2,500 gram. This group of children is considered to have a high risk of neonatal, postnatal, and mortality and the morbidity. Low birth weight is caused by the intrauterine growth retardation, prematurity, or for the both. It contributes to a range of poor health outcomes. Low birth weight is more common in developing countries. However, data on the low birth weight in developing countries is often limited because significant portion of deliveries are occur in homes or either in a small health facilities. So, where the case of the infant with a new low birth weight are unreported. Low birth weight babies have a higher risk of morbidity and the mortality because they have a loose skin fold, absence of subcutaneous fat, and peeling of skin. Low birth weight affects nearly every organ in the body. Some low birth weight babies need special care in the hospital after the birth. They may need help with the breathing, staying warm, protection against infection, and getting enough nutrition. They may have a problem with the lungs, intestinal tract, vision, hearing, and also developmental delay in the future. So nesting is a one comfortable measure that stimulates in utero feeling of the lack of space and make the baby less prone to startle. The infant can be positioned prone or on the side with the flex extremity by providing a nest with the roll cotton or the blanket. Next, move forward to the need of the study. Globally, there are 140 million live births. Among those live births, 20.5 million born with a low birth weight. Among these 20.5 million low birth weight baby mostly born in two major areas of the world, namely Asia and the Africa. India is the sixth place with the rate of the low birth weight baby. About 20% of newborn have a low birth weight. Every 1 in 7 newborn are born with the low birth weight in India. And Gujarat, when we talk about the Gujarat rank at 8th among the 21 big states as far as high proportion of the babies with the low birth weight is a concern. In fact, Gujarat performance deteriorates from the base year to the reference year. The percentage of the low birth supportive study regarding this. Author name is J. Fleb Esther in 2017. So, conduct the study on a study to assess the effectiveness of nesting on biophysiological parameters and sucking response among the low birth weight babies at the Coimbatore, that is in India. Methodology by using the purposive sampling technique. Total 40 samples were collected, 20 in experimental group and 20 in a control group. Babies in experimental group kept in a nesting and babies in a control group were on the routine care. Then pre-test and post-test were taken in both the group. The result of the study reveals that the nesting is effective intervention to stabilize the biophysiological parameters and to improve the sucking response among the low birth weight babies. So now move forward to the objectives of this study. First objective is to assess the biophysiological parameters among the low birth weight babies in experimental and a control group. Second, to assess the sucking response among the low birth weight babies in experimental and a control group. Third one, to assess the effectiveness of nesting on biophysiological parameters among the low birth weight babies in an experimental group. Then next is to assess the effectiveness of nesting on sucking response among the low birth weight babies in an experimental group. Last one is to find out the association between the biophysiological parameters and sucking response in an experimental group with the selected demographic variables. So next is hypothesis. Research hypothesis is there is a significant improvement in biophysiological parameters and sucking response among the low birth weight babies who receive the nesting than the baby who do not receive the nesting. Operational definitions. First one is assess. According to this study, assess means to monitor the biophysiological parameters and estimate the sucking response among the low birth weight babies. Second one is effectiveness. According to this study, it refers to the capacity of nesting that improve the biophysiological parameters and sucking response among the low birth weight babies. Third one is the nesting. According to study, it is an intervention which gives the comfortable flex position to the low birth weight babies by providing a cell-shaped boundary using the roll cotton towel. So next is a conceptual framework. So I use the modified Levin's conversation model for these studies. In that, it includes both external environment and the internal environment. Low birth weight babies, external environment include the parameters like the temperature, noise, surrounding articles, frequent handling of the baby, and the nursing procedure. When we talk about internal, it includes the physiological discomfort, biophysiological instability, poor muscle mass, and last one is a neurological immaturity. So I divided into two groups, that is experimental group and the control group. In a pre-test, I assess the demographic variable of the mothers and the baby, and also assess the temperatures and other physiological parameters. So babies who are belongs to in experimental groups, so provided the nesting, and babies who are belongs to the control group, they are only routine care only. So when I take the post-test, so results show that there is a significant maintenance of the thermal balance and physiological stability and improvement in the sucking response among the low birth weight baby. And in a control group, there is a minimal maintenance of the temperature and other physiological parameters and improvement into the sucking response in a low birth weight babies. So then next chapter is review of literatures. So according to this, I divided into three sections. First section that deals with the theoretical overview regarding the problems of the low birth weight babies. Chapter 2, section 2. Okay, third, studies related to low birth weight babies. And last one is section 3, studies related to the effectiveness of the nesting. Methodology, that is a chapter 3. I used quantitative research approach. Research design was quasi-experimental research design, that is a non-randomized control group design. Study setting was Sachi Children Hospital, Surat, Param Children Hospital and NICU, Surat, Nice Children Hospital, Surat. Population was in that accessible population, neonate with the low birth weight is less than 2.5 kg at selected hospitals, Surat. Sampling technique was non-probability purposive sampling technique, and sample by using this sampling technique, total 60 samples were collected from the selected hospitals. So these samples were divided into two categories. First is experimental group and the second one is a control group. And by using the parameter like pulse oximeter and thermometer, I assess the parameters, and by using the modified scale for the sucking response, I measure the sucking response. And when then babies are in experimental group were kept in a nesting, and babies who are in a control group, there are no routine care. After the reassessment was done for the both group, then data analysis, and last one is study findings and the conclusion. So this is the schematic presentation of the research design. That is, some two group are there, experimental group and the control group. Post the pre-test was taken in a both group, and only babies who are in experimental group, they are kept in a nesting, and post-tests were taken for the both the group. Variables are number 4. First one is the independent variables. It includes that nesting of the low birth weight babies. Dependent variable, biophysiological parameters and sucking response of the low birth weight babies. Demographic variable include 2, mothers and the child. Mothers include the age, parity, risk during the pregnancy, mode of delivery and birth spacing. Child include the age in days, birth weight, gestational age at the birth, birth order of child and mode of sucking. And last one is a confounding variables, that is a radiant warmer and warmness from the mother. Criteria for sample selection, it includes 2, inclusion criteria and the exclusion criteria. In inclusion criteria, low birth weight babies whose parents are permitting to provide nesting to their baby. Second one is low birth weight babies who are admitted in the hospital and stay for at least 3 days or the more. And last one is mother of the neonate who could understand the speak Gujarati language. Exclusion criteria include neonate who are on a CPAP or the ventilators, neonate who are diagnosed of the severe medical and surgical condition. Third one, neonate who are with the major congenital anomalies. And last one is neonate whose Apgar score is less than 7. So this is the method of data collection. First, formal administrative permission was obtained from the concerned hospital authority, and then by using the non-probability sampling technique based on the inclusion and exclusion criteria, 60 samples were collected from the selected hospitals. Then informed consent were taken from the participant. Last, that is the demographic data of the mother and the newborn were obtained from the mother by using structured interview method, and clinical data were collected from the case record. First, the biophysiological parameters and sucking response assessed in both experimental and control group. Then the babies who are in experimental group were kept in the nesting for the next 2 days. Nesting was provided for the 6 hours per day. Then again biophysiological parameters and sucking response were assessed in both experimental and control group, and then analysis and interpretation of data were done. So chapter 4 is analysis and interpretation of the data. This section deals with the frequency and percentage distribution of the demographic variable among the low birth weight babies. First one is the age of the mothers. In age of the mothers, majority of mothers in experimental group belongs to the above the age of 30. In a control group belongs to the 21 to 30 years. In a parity, in experimental group, majority of mothers are the multipara. In a control group also, majority of mothers are multipara. This during pregnancies. In experimental group, majority of the mother has no complication, and control group also, majority of mother has no complication. Mode of delivery. In experimental group, majority of mother has a normal vaginal delivery, and control group also, majority of mother has a normal vaginal delivery. Birth spacing. In experimental group, majority has the majority has not applicable because they are the primipara, and control group also majority has not applicable because they are the primipara. Second section deals with the frequency and percentage distribution of the demographic variables among the low birth weight babies. The first one is the age. In experimental group, majority are from the first day, and in control group majority were in a second day. Birth weight in experimental group, majority of belongs to the age group, that is 1.5 to 2.0 kg, and control group majority of belongs to the 2.1 to 2.4 kg. Next is the gestational age at the birth. In experimental group, majority of from the 35 to 37 week. In control group also majority from the 35 to 37 week. Birth order of the child. In experimental group, majority of childs are the second born, and control group or majority of child is the first born. Mode of sucking. So in experimental group, majority are in a nutritive sucking, and control group also majority from the nutritive sucking. Section 4. This section deals with the frequency and percent distribution of the score among the low birth weight baby in experiment and a control group. In experimental group, when we take the pre-test, majority of belongs to the poor sucking response, and when we take the post-test, majority of belongs to the fair sucking response. In a control group, so majority of belongs to the fair, and then the post-test also majority belongs to the fair sucking response. Next section is deals with the mean and standard deviation among the low birth weight babies. So in a pre-test mean was 10.33 and post-test mean was 20.27. In a control group, pre-test mean was 10.2 and post-test mean was 15.63. Next section about the comparison of the pre-test and post-test score. So first one is a comparison about pre-test post-test among temperatures. In that experimental group, calculated value is a higher table value. It indicates that research hypothesis is accepted. Second, comparison about DIT pulses. In that also the calculated value is higher than the table values. It also indicates that research hypothesis is accepted. Respiration, same as that, calculated value is higher than the table value. It indicates that the research hypothesis is accepted. And last one is the SpO2, that is oxygen saturation. In that also, calculated value is higher than a table value, that indicates that the research hypothesis is accepted. So here's comparison of the and post-test among the sucking response of the low birth weight babies. In that also, calculated value is higher than the table value. It indicates that research hypothesis is accepted. So next section is deals with the comparison of the biophysical parameter among the experimental group and the control group. So if I use the unpaired t-test, also indicate that calculated value is higher than the table value. So research hypothesis is accepted. In pulse also, calculated value is higher than the table value. It indicates the research hypothesis is accepted. In respiration also, calculation is higher than the table value, so research hypothesis is accepted. Same is in SpO2 also, calculated value is higher than the table value, so research hypothesis is accepted. So this section deals with the comparison in a sucking response. So as we see that calculated value is higher than a table value, so research hypothesis is accepted. So this section deals with the association with the demographic variables. When we talk about the temperature, so age of the mother and the age in a days in a children and birth weight and gestational age at the birth has a significant association with the demographic variables. The second one is pulse. In pulse, there is a in a child age in days, birth weight are the association. Third one is the respiration. In respiration, birth weight and gestational age at the birth are has a significant association. So in SpO2 also, there is a age in days, birth weight and gestational age at the birth are has a significant association. So in sucking response, age in days, birth weight, and gestational age at the birth has a significant association with the sucking response. So next the discussion. So first one is, so I read a discussion based on the objectives of the studies. The first objective is to assess the biophysiological parameters among the low birth weight babies in experimental groups. So these indicate that standard deviation and mean is significantly higher in the post-test in experimental group. So indicate that it is effective on the low birth weight babies. So, in assessment of the sucking response among the low birth weight babies, in a pre-test, the majority of child belong to the poor sucking response. So then effectiveness of the nesting on biophysiological parameters. So as we discussed that tabulated value is lower than the calculated value. So in all temperature, pulse, respiration and SpO2, the research hypothesis is accepted. It indicates that nesting is an effective intervention on low birth weight babies in a biophysiological parameters. So next is the nesting, effectiveness of nesting on sucking response. It also indicates that table value is lower than the calculated value. So it indicates that so research hypothesis is accepted and nesting is effective on the sucking response. So last one is association. So in a temperature, age of the mother, age of the baby, birth weight and gestational age are the significant association. In temperature, age of the child, babies and the birth weight has a significant association. In respiration, there is a birth weight and gestational age has a significant association. In SpO2, age in days, birth weight, gestational age and mode of sucking has a significant association. In a sucking response, birth weight, gestational age and mode of sucking has a significant association. So major findings of these studies. So in a major findings in experimental group, like a majority of pre-test, majority of belongs to the poor sucking response. In a control group, also majority of belongs to the poor sucking response. After implementation of the nestings in experimental group, majority of belongs to the fair sucking response. In a control group, majority belongs to the poor sucking response. Then nursing implications. So care of the tiny of the low birth weight baby is a primarily concern with the health workers. The present study is effectiveness of nesting on biophysiological parameters and sucking response. It helps stabilize the biophysiological parameters and improve the sucking response among the low birth weight babies. So this method is an additional therapy and it can be used as a nursing intervention in a care of the low birth weight babies. And this study can be implemented in several fields like in nursing practice, nursing education, nursing administration, and the nursing research. Recommendation. So this study can be conducted by using a large sample. So thereby the findings of the study can be generalized. Study can be conducted to find out the factors that influence the biophysiological parameters and sucking response of the low birth weight babies. Next one is a comparative study can be conducted to assess the sucking response among the low birth weight babies on direct breastfeeding and express breast milk formula. Then study can be conducted to assess the effectiveness of structured teaching program on knowledge and practice regarding handling the low birth weight babies with the nesting among the NICU staff nurses. A study can be conducted to assess the effectiveness of nesting on length of stay in a hospital. And last one is study can be conducted on the effectiveness of nesting on neurobehavioral activity among the low birth weight baby. And these are the reference of the study.
Thank you so much for giving me this opportunity.
At the outset, I'd like to thank the organizers for the opportunity. I'm here to talk about the gap between nursing research and nursing practice, pediatric nurses concerned. The integration of nursing research into clinical practice is essential for developing and delivering quality care, evidence-based care, particularly in pediatric nursing, where the needs of young patients and their families are unique and complex. Despite the wealth of research available, a significant gap often exists between what is known and what is implemented in practice. Factors such as limited awareness of the current research contribute to this disconnect. By actively engaging with research, advocating for evidence-based practices, and participating in collaborative efforts with researchers, pediatric nurses can enhance the quality of care provided to children. Furthermore, their role in educating families about evidence-based interventions fosters a supportive environment that encourages active participation in care decisions. So, some of the factors which we need to think are lack of awareness. Many nurses may not be aware of the latest research findings and how to access them. Time constraints. Nurses are busy with the clinical workload, and nurses often face heavy workloads, leaving little time to engage with research or implement the new practices. Educational barriers. Not all nursing programs emphasize the research or evidence-based practice, leading to variability in knowledge and skills among practitioners. Institutional resistance. Sometimes this is also one of the factors which hinders. Some healthcare institutions may resist changing establishing practices, making it challenging to integrate new research findings. And communication gaps. There can be a disconnection between the researchers, practitioners, the teachers, the nursing faculty, with research findings not being effectively communicated in a practical context. When they work together as a team, then they can be give and take, and where there can be translation of research evidences into practice. Lack of resources is the other important factor which we need to bear in mind. Limited access to resources such as research, database, or continuing education can hinder nursing ability to stay updated. So bridging this gap, fostering a culture of evidence-based practice is so important in the pediatric nursing field. So the gap between nursing research and clinical practice is a well-documented issue that affects healthcare delivery across various specialties, including pediatrics. Despite advancements in research methodologies and a growing body of evidence, the translation of research findings into everyday clinical practice remains a challenge. This gap can lead to a suboptimal care where patients may not benefit from the latest evidence-based interventions, ultimately impacting health outcomes. So in pediatric nursing, this gap is particularly critical. Children are not simply small adults, they are angels. They have unique physiological, developmental, and psychological needs that require tailored care approaches. The complexity of pediatric healthcare demands that nurses not only stay informed about the current research, but also apply it effectively in their practice. However, the barriers such as time constraints, limited access to research resources, and inadequate training in research utilization often hinders this process. Pediatric nurses frequently serve as advocates for their young patients and their families. This role positions them to identify gaps in care and push them for integration of evidence-based practice into clinical settings. By fostering strong relationships with families and engaging in open communication, pediatric nurses can better understand the needs of their patients and challenges they face, thereby promoting a collaborative approach to care that is informed by research. Recognizing these factors is essential to explore the specific strategy pediatric nurses can employ to bridge the research practice gap. By doing so, it can enhance the quality of care pediatric patients can receive, making it evidence-based one. There are many studies which prove the gap. A study by Valentin et al. In 2014 examined the barriers that nurses face in implementing evidence-based practices. The findings highlighted issues such as time constraints, lack of access to research, and insufficient training in evidence-based methodologies. Knowledge translation in pediatrics, a systematic review by Brawl and Grimshaw in 2003 focused on knowledge translation strategies in healthcare, especially in pediatrics. The review identified effective interventions for bridging the gap, including educational outreach and the use of clinical champions. Impact of continuing education. Research by Upton and Upton in 2006 found that continuing education programs significantly improve pediatric nurses' knowledge and application of evidence-based practices. The study emphasized the importance of ongoing professional development in fostering an evidence-based culture. Role of pediatric nurse practitioners. A study by Mott et al. In 2020 investigated the role of pediatric nurses practitioners in implementing evidence-based practices. The findings showed that these practitioners not only applied research findings in their clinical settings, but also served as leaders in promoting evidence-based care among their peers. Patient and family education. Research by Gone et al. In 2019 explored the effects of involving families in care decisions based on evidence-based practices. The study demonstrated that educating families about research-informed interventions led to improved health outcomes and increased satisfaction with care. Collaborative practice models. A study by et al. In 2016 evaluated the impact of interprofessional collaboration on the implementation of evidence-based practices in pediatric settings. The results indicated that collaborative models improve communication and enhance the application of research findings in clinical practice. These studies collectively underscore the importance of addressing barriers, enhancing education, and fostering collaboration to effectively bridge the gap between research and practice in pediatric nursing. So, I'd like to conclude that there is evidence that gap does exist between pediatric nursing practice and the research that go on in the field. In our own institution, in my own area, we have done some researches, especially the postgraduate students and even the nurses for that matter, and faculty as well. And we have translated some of the evidences like where the effectiveness of oxygen delivery by nasal catheter or by tent method. And the research showed that nasal catheter method is far superior and therefore that is adopted. Likewise, so many examples were reported. Use of thrombophobe for extra infiltrations, IV infiltrations, where that was found to be superior than the eye supplication or involved result application. Use of amniotic membrane for burn care, and the paracetamol versus paracetamol and temper sponging for children with fever, where there was no evidence to say that one was superior than the other, and therefore we have outdated the temper sponging process. Likewise, we can put so many examples where the evidences have been translated into practice. Even for obesity, the Zumba exercise and the teaching program are found to be very effective in bringing about a reduction in BMI in children who are obese and mobile with that. Therefore, we are implementing that in the school health programs. So, bridging the gap between nursing research and practice is essential for improving patient outcomes in pediatric nursing. The existing literature highlights various barriers that pediatric nurses face, including time constraints, limited access to research, and insufficient training. And so we need to focus on the lacunae and improve on so that we will be able to provide quality care by translating the evidences into clinical practice. Thank you for the opportunity, and God bless us all. Thank you.
First of all, I would like to introduce myself as Mirza. I belong to the Institute of Zoology, University of the Punjab, and here is the research. The title of the research is Hematology Pharmaceutical Investigation of cryptorinic acid and RBFC in the common quills. This was the research is done from the Gandhi University, Khan, and here is the abstract. In this study, investigated the hematological and serum biological parameters in the common quills to evaluate the safety of steroids treatment. The research involved hundreds common quills with the 100 common quills with 18 assigned to treatment groups and 20 served as a control group. The treated group was divided into two trials. The first one is there are two trials. The first one is that contain 40 birds, and the each trial include subgroup receiving either serpturin and ethinyl estradiol or human gonadotropin, with each subgroup consisting of 20 birds treated for varying duration. of 5, 10, and 5, 10, 15, and 20 days. Key hematological parameters measures included blood pH, red blood cells count, white blood cells count, and packed cell volume, and the mean corpuscular volume. Additionally, we assign serological parameters such as total protein, albumin, and uric acid, cholesterol, and creatinine, alanine, and aminotransferase, aspartate aminotransferase, and creatinine kinase, and acetylene cysteine. Through the study, we observe various clinical signs in treated foods, including feeder loss, swelling of feet, and liver discoloration of the liver and testis internal hemorrhage. Those of appetite, depression, and webbing of internal organs. Notably, partial mortality occurred across all the trend subgroups. The result indicated that CPA or EE administration increased uric acid, cholesterol, and total protein while decreasing the white blood cell, red blood cell, and conversely, HCG treatment resulted in decreased level of ALT, AST, total protein, albumin, CK, MP, but an increase in RBC count, white blood cell count, PCV percentage, and MCV. Important CK, NSC, and ALT level show no significant changes. This research highlights significant hematological and serological alterations induced by steroids treatment in the common quiz. This finding underscored the need to carefully monitor these parameters to ensure animal welfare during the therapeutic interventions. Here's my biography. I'm Hassan Reza, completed my MPhil at the age of 26 in the Zoology, Institute of Zoology from the University of Punjab, Pakistan, and I'm working as a currently research assistant in the paleontology lab of Institute of Zoology. I have 4 publications, 3 with the high-ranked international publications, and one of our local journals. Here's my email, and here's my profile. Thank you very much, sir, for the abstract presentation, giving me opportunity.
I am Yaqub Mattai from Kerala, India. Today I want to discuss with you. Subject is paracetamol is the most unscientific and dangerous drug for fever. Anyone can create a fever within hours using antipyretic objects. Introduction. Any substance that is cooling or reducing temperature, that means antipyretic is a fever stimulant because it increases inflammation and reduces blood flow. Antipyretics are the only substance need to induce fever and hypothermia in any organism. Paracetamol is an antipyretic substance. Anyone can create a fever within hours using antipyretic objects. Next one. Paracetamol cures fever and causes fear. Ignorance of the subject is the root cause. The medical book states that paracetamol may cause fever, neutropenia, thrombocytopenia, and skin reactions. This is not a side effect of paracetamol, but it's a proper function. Next. If it is said that the medicine used to reduce the temperature of fever itself causes the fever, the scientific and authenticity of that medicine are being questioned here. There is no science or technology like this anywhere in the world. Next. Today, hypothermia is called fever. As we are aware, today hypothermia and fever are divided into three categories based on the severity of the temperature. First one, the mild low-grade hyperthermia. Its temperature range is 100.5 degree Fahrenheit to 102.2 degree Fahrenheit. The same temperature is used to determine mild or low-grade fever. Next one is moderate grade hypothermia. That is, its temperature range is 102.2 to 104 Fahrenheit. The same temperature is used to determine moderate grade fever. Next one is high grade hyperthermia. That is greater than 106 Fahrenheit. The same temperature is used to determine hyperpyrexia. Next one. Hypothermia is a hypothermia cannot be created by fever creating agents. Fever cannot be created by hypothermic agents. The source of fever and the source of hypothermia are not the same. Fever does not occur from the source of hypothermia. Hypothermia does not arise from a source of fever. Next. Lower the temperature will not occur the fever. A decrease in temperature is not enough to reduce the fever. All substances and their functions which only increase and decrease during fever must return to the state they were in when there was no fever. Next one. Pyrogens which raise the temperature during fever are not only immune system created. Therefore, if prostaglandin is reduced with the paracetamol and the temperature is reduced, the fever will never go away because all the substances produced only during the fever and their functions will not return to their old form. Next one. Hypothermia cannot be. Most of the people is Most people mistake fever as high temperature and think it is a dangerous and take paracetamol to reduce temperature as fever is determined by checking temperature. A high temperature is not a fever but hypothermia, which is the opposite of fever. Hypothermia has none of the features of fever. Fever and hypothermia are mutually exclusive. Next one. Hot objects of the same temperature as fever or heat producing substance cannot cause fever in any living being. Any substance that is hot or heat increasing, that is means pyretics, are the only substance need to cure fever in any organism. In hypothermia, the temperature does not come from the same source as in fever, so there is no similarity between what happens when there is fever and hypothermia. They are contradictory. Next one. The only cause of fever is inflammation, but the only cause of hypothermia is high heat. Antipyretic fever treatment never reduces inflammation but increases it. Fever is temperature works against lack of blood flow and increases blood flow. Since inflammation is the only cause of fever, symptoms, signs, signals, and actions are shown when inflammation occurs. That is why the body hates cold and likes heat during fever. Next one. The body's lack of heat energy prompts the immune system to produce warm substances such as prostaglandin to constrict blood vessels under the skin to conserve and prevent the heat loss of body heat. Reduce the fire rate of warm W neurons that sense heat and increase the fire rate of C neurons that sense cold. Next one. Similarly, in hypothermia caused by extreme heat, symptoms, signs, signals, and actions of overheating are shown. This is why the body hates heat and loves cold when hypothermia occurs. Next one. The essence of today's fever treatment is fever can be cured by using fever creating substance. Here we consider the basic contrast between the basic action of fever and the basic action of paracetamol. Next one. Paracetamol is given to reduce prostaglandin 2, which increases temperature. Prostaglandin 2 is not a fever-causing substance. It has hypothermic, vasodilatory, and anti-inflammatory properties. Hypothermic substance never cause fever they cause hypothermia, the opposite of fever. Next one. The heat of fever and the prostaglandin are the most abundant substance in the body during fever. It is more abundant after the inflammation in the body. They are not abundant before the inflammation. Prostaglandin is found in the body during fever, similar to airbag used to protect passengers in a car accident. Next one. Any substance that is hot or heat increasing, that is pyrostatic, is a fever reducer because it reduces inflammation and increases blood flow. Endothelial cells produce prostaglandin, which is an important part of immune system. The endothelial cells are the main regulator of vascular homeostasis. Next one. Paracetamol, which reduces prostaglandin, is given for fever, making this as the cause of the fever. Paracetamol destroys prostaglandin without being recognized by the immune system to increase blood flow and reduce inflammation. Fever does not go away if heat-producing substances are removed from the body. Fever can only be relieved by avoiding substances that reduce heat in the body. Next one. Paracetamol, which reduces prostaglandin, paracetamol is given to patient to eliminate prostaglandin found in fever, just as those who do not know the purpose of an airbag in a car accident disability, thinking that someone will die in a serious accident because of the airbag. As a result, the body cells blood flow decreases and the patient dies. Next one. Paracetamol works in favor of inflammation, which is the underlying cause of fever. Paracetamol also destroys prostaglandin, a heat-sensitive pyrogen produced by endothelial cells to reduce inflammation and increase blood flow. Paracetamol does not reduce the underlying cause or symptom of fever, disease, or cause of disease, but increases it. Next one. Antibiotic therapy is necessary and appropriate treatment for hyperthermia and not for fever. Next one. Paracetamol does not reduce fever, the cause of fever, morbidity, or mortality, all of which are increased by paracetamol. Paracetamol destroys all the protective substances our immune system makes when we get sick. It decreases prostaglandin, glutathione, interferon, platelets, WBC, etc. Next one. Even for diseases that would have cured themselves due to the action of our immune system, using paracetamol can cause inflammation, reduce blood flow, and death. A claim to cure fever by using fever-creating substances is not called a treatment, it is a murderous attempt. Next one. Paracetamol is the most dangerous medicine for fever. Those who have proper knowledge about fever and the action of paracetamol. Without knowing this, paracetamol is a fever reducer for those who firmly believe that fever occurs when body temperature rises above 38 degrees Celsius and the fever disappears when the temperature drops. Next one. Medical book says that antibiotic cause prolonged infection which increase death. This is not a side effect of antibiotics, but it's a proper function. Paracetamol is a antibiotic medicine. Depletion of prostaglandin 2 and glutathione, which reduce inflammation, can also increase inflammation. No such a treatment or science was found even in the Stone Age. Next one. Paracetamol is prescribed for many painful symptoms and ailments. Many ailments like back pain, neck pain, and joint pain are caused by inflammation. Paracetamol to relieve the pain re-inflames the inflammation. Reducing heat-producing prostaglandin will never reduce inflammation but increases it. Next one. Most of the people who took paracetamol reported that their fever went away when they took paracetamol. Is this correct? That is another question. The question is whether these people to know what fever is to know if this experience is true. Next one. All those who share this experience are those who did not know what is the correct definition of fever and mistake it for fever when the temperature rises above 38 degrees Celsius and felt that the fever went away when the temperature decreased. The only way to change the misconception is to understand what the correct fever definition testing are found. What happens when you only have a fever? Next one. The reality of paracetamol experience can be realized if one also recognizes the fact that anyone can get a fever with antibiotics alone, and that fever is defined, tested, and treated as hyperthermia at temperature greater than 38 degrees Celsius. That has no resemblance to fever. Next one. Conclusion. From the above evidence, paracetamol is the most unscientific and dangerous drug for fever. Anyone can get a fever within hours with antibiotics. Antibiotic treatment for fever is wrong, and paracetamol will not help cure fever. Fever is caused by destroying the immune system in any way. Fever heat to increase blood flow, and fever needs paracetamol treatment. Next one. No other illness or symptom is more unscientific than justifying the administration of paracetamol for fever. No disease requires paracetamol to reduce the temperature. Paracetamol is also not effective in hyperthermia, where it is necessary to reduce the temperature. So giving paracetamol for fever should be banned as soon as possible. There is no other disease or symptom that is more unscientific than the assessment of fever. The same is true of paracetamol as it is of fever. Next one. There is not even 1% evidence that paracetamol helps the immune system in any way. At the same time, there is 100% evidence that it destroys the immune system. Taking paracetamol for fever is suicidal. Next one. That is reference. Next one. Thank you. Hear me patiently suffer. If you have any questions, you can contact my WhatsApp number or personal email ID. This paper is also published in a journal. After 5 minutes or 1 or 2 minutes, I will share the link of that paper.
I'd like to thank the organizers of this meeting for the invitation to present this talk today. Also, I wish to thank all of you online attending this meeting and attending my talk. So today, I'm going to talk about how the nanomorphology impact magnetic hyperthermia performance. So here is my outline for today. I briefly will comment you about magnetic hyperthermia, what that means, and then I will shortly introduce the magnetic hyperthermia basics and some details of the instrumentation design, and then I will skip to the challenge and targeting of magnetic hyperthermia. So how to go around the challenge, and so I will present some possible solutions, like for instance, the instrumentation and the magnetics design. Then I will show you some interesting results about magnetic hyperthermia in tumor therapy. And the last topic of my talk will be some comments about the so-called Box-Lucas model. And then conclusions about my presentation. So as you can see on the lower part of my slide, there is a very strong statement made by Hippocrates for 60 to 370 AC. So Hippocrates is actually this Hippocrates is Hippocrates II, and this is the father, considered the father of the modern medicine. So as you can see, this statement is written in Latin, and likely most of you may not read Latin. So here in my next slide, I show you the translation from Latin to English. And this is the basics of magnetic hyperthermia. So it says, those diseases which medicine do not cure, knife cures. Those which knife cannot cure, fire cures. And those which fire cannot cure are to be reckoned wholly incurable. So as you can see, it's a very strong statement. And this is the first report about magnetic, about hyperthermia. So hyperthermia in the modern time, in the last 20 or 30 years, has been performed using nanoparticles. And there are two ways to perform hyperthermia today. One is the magnetic hyperthermia, using magnetic nanoparticle. And the other one is the optical hyperthermia, using specifically some metal nanoparticles like gold and silver. What is the difference here? So magnetic hyperthermia is based on the magnetic hysteresis curve. However, the optical hyperthermia is based on the surface plasma resonance. They are quite different mechanisms. What is a very important difference between magnetic hyperthermia and optical hyperthermia? So magnetic hyperthermia allows you to promote remote manipulation of the magnet nanoparticles. And in addition, it allows you to perform remote heating. So you can apply external AC magnetic field. That is what is the meaning of remote heating. On the other hand, the optical hyperthermia, it does not allow you remote manipulation of the metallic nanoparticles. And likewise, it does not allow you to perform remote heating. Why is this? Because it requires application of a laser light. And the penetration of the laser light in the skin, in the body, is quite limited. Maximum, perhaps 7 to 8 millimeter, depending on the wavelength. So it seems right at the beginning, the magnetic hyperthermia has more capability to handle the hyperthermia than the optical hyperthermia. So let me briefly comment about the basics of the magnetic hyperthermia. On the left-hand side of my slide, you can see a sketch of spherical nanoparticles, and they are magnetic. You can see the magnetic moments on the magnet nanoparticles. If there is no applied external field, the net magnetization is zero. Why is that? Because the magnetic moments of the nanoparticles, they align randomly, and so they cancel each other. However, if you apply an external magnetic field, all the magnetic moments they align with the external field, and then the net magnetization is not zero. However, if you shut off the magnetic field, the magnetic moments will relax back to the random orientation. And that relaxation, it takes time. And there are two mechanisms of relaxation. One is called the neo-relaxation time. And neo-relaxation time is the relaxation of the magnetic moment inside the crystal structure of the magnet nanoparticle. On the other hand, the Brownian relaxation time on the right-hand side here. It means the relaxation, the randomization of the magnetic moments by the randomization of the orientation of the nanoparticles themselves. So it means nanoparticles, they turn around until the orientation of the magnetic moments are randomly placed in the space. So actually the net relaxation time is a combination of neo-relaxation and Brownian relaxation. So the net relaxation time scales with the neo-relaxation and Brownian relaxation, like I can show you in this expression. Actually, the frequency of the net frequency of relaxation is the neo frequency plus the Brownian frequency of relaxation time. Okay, so bearing in mind that we have these two relaxation mechanisms, we can understand the process of generating heat. So let's say to generate heat, you have to apply an external AC magnetic field. When you do this, the magnetic moment try to follow the external applied AC field. And there is a very important relationship between the net relaxation time and the typical time of changing the AC magnetic field. So if the typical time of reversal of the external applied field is higher than the relaxation time, so it means that the nanoparticles have enough time to follow the applied external field. And you see a hysteresis curve like the upper plot here. However, if the typical reversal time of the external field is smaller than the typical relaxation time, the hysteresis curve just open up, like I can show you here in the lower part of my slide. So the hysteresis has a cycle with an effective area inside the cycle. And this area provides you the mechanism of the magnetic hyperthermia. The area here scales with the amount of heat the nanoparticles can deliver to the site where they are located. So this is the basic, this is the basic mechanism of magnetic hyperthermia. But remember, this area is a result of the net relaxation time, which means a combination of neo and Brownian relaxation time. So the heating can come from the neo mechanism, or it can come from the Brownian mechanism. The Brownian mechanism is the mechanism that the particle rotate itself in the medium. So keeping in mind and focusing on magnetic nanoparticles to promote magnetic hyperthermia, the first aspect is the remote manipulation, which means you can use gradient of magnetic field, external gradient of magnetic field as pliers. So you can move around the nanoparticles, the magnet nanoparticles, and eventually you can locate them in a special spot, the one where you want to promote heating. So, and the force applied to the magnet nanoparticles due to a gradient of magnetic field scales with the DC susceptibility, and also scales with the size of the nanoparticle, the volume of the nanoparticle. And the heating is promoted by the amplitude of applied external field, the frequency, the AC susceptibility. So the heating, how much the temperature is increased due to the magnetic hyperthermia, scales with all these parameters. So the time, delta T, is the time that the AC field is applied. Here we have the amplitude of the applied external field square, the frequency, AC susceptibility, and inverse of the specific heat of the medium. So these two relationship gives you an idea how to control and how to manipulate the magnet nanoparticles and place them to the right site where you want the magnetic hyperthermia effect takes place. So remember, the heating depends on the time you are applying the external field, depend on the amplitude of the external field, and depend on the frequency, which means these three parameters actually are instrumentation parameters. On the other hand, the AC susceptibility, it is a parameter related to the magnet nanoparticle itself. And the specific heat depends on the medium. Okay, so in terms of instrumentation design, we can manage the heating. Here is again the expression of how much you can increase the temperature when you perform magnetic hyperthermia. So you can modulate this heating by doing electronics, which means the time you applied the external AC field and the amplitude of the AC field and the frequency of the AC field. This is the instrumentation parameters you can control. Of course, you can extract the temperature, which is a very important experimental parameter. So you can control how much you are heating your sample. But also it depends on the magnetic characteristics of the nanoparticles you are using to perform the magnetic hyperthermia. In particular, it depends on the specific heat of the medium and the nanoparticle, and the AC susceptibility of the nanoparticle. So you can control the heating. At the end, you can control the heating by controlling your instrumentation parameters and also controlling the particular characteristics of the magnetic nanoparticles. Okay, here is one example how the heating of the nanoparticles, how you can measure the heating of the nanoparticles. So this experiment is reported in this paper. This is a group from Dr. Huger in Jena in Germany. So what they did, they use a new mice, they plant a tumor on the backside, and then they injected magnetic nanoparticles in the tumor. So they could measure the temperature of the tumor and the temperature of the body. And then they plot here the temperature of the tumor. So it as a function, so temperature here is in Celsius, as a function of time that the AC field is applied in seconds. So they go up to about 5 minutes application of AC magnetic field. And you can see the temperature of the body is almost constant, a little bit lower 30 C. However, the temperature of the tumor goes up close to 70 C. So here is a very important border. And the big challenge of magnetic hyperthermia is to keep around 43 C. Why is that? This is a very important border in magnetic hyperthermia if you are using magnetic hyperthermia as a cancer therapy. So around 43C, you perform what they call thermal sensitization, which leads the apoptosis of the tumor cells. If you go higher than 43C, and the higher you go, the more strong the process is. So you go to the thermal ablation, which leads to necrosis. Okay, what is the main difference between necrosis and apoptosis? So the thermal ablation leads to necrosis, which means the disruption of the tumor cell membranes. On the other hand, if you keep around 43C, and then you go apoptosis, and apoptosis is thermal sensitization. What it does, it damages the mitochondria. And once the mitochondria is damaged, it triggers the apoptosis of the cell. So the big difference is in the thermal ablation, you induce in the body a very strong reaction from the immune system. So, and this strong reaction is not desirable. So the big challenge of the magnetic hyperthermia, as far as the cancer treatment is concerned, is to keep the temperature around 43C and then perform apoptosis and not necrosis. Necrosis leads to very strong inflammation, and this is not desirable. Okay, so how we can go around and keep the heating around 43C and then perform thermal sensitization. We have two ways. We can work on the instrumentation, and of course we need a temperature sensor, and we need an electronic control to control the frequency of the AC field, the amplitude of the AC field, and the total time of application of the treatment. On the other hand, possible solution is the magnetic nanoparticle design. So we can play with the phase of the material, with the shape and size of the nanomaterial. So in terms of instrumentation, I would like to call your attention that the same magnet nanoparticle you can use to perform magnetic hyperthermia. Also, you can use as a nano thermometer. So here is a paper showing how you can use the same magnetic nanoparticle to perform magnetic hyperthermia and also to extract the temperature precisely with a precision better than 0.05 C. So in terms of sample design, let me show you one example. In this example, we took a standard magnet nanoparticles, magamite, and then we coat magamite with a thin layer of gold. And actually, we produced two samples. The first sample is a very thin layer of gold, and the second sample, the surface layer was thicker. So we have two samples. In terms of particle size distribution, you can see here on the right-hand side, the upper plot shows the particle size distribution. The histogram, the blue histogram, is the naked magamite nanoparticles. And then with the first coating, the thinner gold layer on top of magamite, you can see the gray particle size distribution here. And you can see that the mean size slightly shift to higher values. And then when we coat with a thicker layer of gold, we can see the red particle size distribution and the red curve, which is even shifted to higher mean particle size. So we can modulate the thickness of the gold layer on top of megamite nanoparticles. Besides, of course, we can modulate the mean size of the core magnetic nanoparticle. Okay, when we perform magnetic hyperthermia with samples, we can, for instance, look at the response, the temperature versus time curve. And on the left-hand side, lower part of my slide, I can show you what is the response when we are using 112 kilohertz AC magnetic field at amplitude of 18 millitesla. And then you can see the response of the 3 different samples. The blue data shows you the trend, the typical trend of the temperature. But you can see that the asymptotic temperature goes higher than 50 C, which means if you operate this one in a standard magnetic hyperthermia treatment, you are going to perform necrosis. However, if you look at the data with the thinner layer and thicker layer of gold on top, so the temperature, the asymptotic temperature goes below 40 C. So it not even cross the 40 C, and then it's not desirable. Both conditions are not desirable. However, if you take the same samples and change the AC frequency from 112 to 631 kilohertz and lower with the amplitude of the AC field by half from 18 millitesla to 9 millitesla, and then you can check the response. So the uncoated megamite nanoparticles go higher in asymptotic temperature, goes higher than 70 C, which is not desirable. However, the thinner coating gold on top of megamite, the same megamite nanoparticles, it goes exactly in the range which is desirable to perform magnetic hyperthermia in terms of thermal sensitization. So what these two data can show you is that you can manage it to find the combination of parameters, sample plus instrumentation, in such a way that you can work your magnetic hyperthermia effect and set the final asymptotic temperature in the right region to perform apoptosis, which is desirable. So all these curves here, so the temperature dependence, the time dependence of the temperature, it goes with this phenomenological expression called the Box-Lucas, where we have the asymptotic temperature and the heat transferring time, the typical heat transferring time, which is a very important point. Okay, so let me show you a very interesting result from magnetic hyperthermia. It is in the range of thermal sensitization, actually. So this experiment was reported by the Japanese group. It's a very important data. So here is a rat, a mouse, sorry, and then you can see that it was implanted tumors on both sides of the body, and they record the temperature in the tumor, and this is the lower tumor is the one they injected magnetic nanoparticles, actually magnetite nanoparticles. On the upper tumor, they didn't inject anything, but they recorded the temperature in the upper tumor, in the lower tumor, and in the body. And you can see in the plot here how the temperature goes with the time of application of the AC field in minutes. So they went up to 30 minutes. And you can see that the temperature in the tumor saturates is asymptotic around 45 C. Okay, so they performed the magnetic hyperthermia. This is the frequency of the field they applied, and the amplitude was 380 millitesla. They applied for 30 minutes, like you can see in the plot, and 3 times a day. So the treatment, after 1 month of treatment, you can see both tumors completely removed from the body. So they use about magnetite nanoparticles, about 10 nanometers in diameter, and they use this magnetite inside the cationic liposome. So it's a magnetoliposome treatment. So this is a very important result in the literature, perhaps one of the most intriguing results in the literature in the magnetic hyperthermia used for tumor treatment. Again, let me take the experiment from the German group in Vienna. So here is how they performed. They injected also magnetite nanoparticles in the tumor. The magnetite was about, again, 10 nanometers in diameter, and they were coated with dextran. And so they injected, and they applied the magnetic hyperthermia with this frequency, 450 kilohertz, and 140 millitesla. And they performed this with 12 minutes in a single treatment. Remember the curve of these, the temperature went, the temperature went a little bit over 70 C. And what happened? Completely remission of the tumor. But this was not thermosensitization, but it was thermoablation. So what happens with the tumor cells was necrosis, actually. Okay. So let me make a comment about the Box-Lucas model. So actually, the Box-Lucas model has been used for over a decade as a phenomenological expression, but you can extract this expression from the first principles. So let's say you have the magnet nanoparticles in the core, you have a thin layer, it could be a shell layer like metallic, like gold or silver, or it could be the cationic liposome or any coating like dextran. Okay, so the magnetic hyperthermia effect, it applies to the core magnetic nanoparticles. And then it hits up the core magnetic. And then there is a transferring, the heat transferring. And we call this the HS is the thermal current coming out from the magnetic core to the environment. So we can extract, we can correlate the thermal current with the rate of production of heat. So the heat production rate actually is the definition of the thermal current. And then we can scale the thermal current with the thermal conductivity and the area across which the heat is transferring and the gradient of temperature. So we can manipulate this expression, of course, in this way. If you take a spherical system, and then the area goes with 4 times pi times r square. Okay, we can manipulate the expression, and then we can integrate both sides of this expression. So if you take the thermal current is constant, comes out from the integral, and then we can integrate from r, which is the radius of the nanoparticle, up to the external part, if we take the thickness of the layer like E. So we integrate from R to R plus E. So this is the thermal transferring from the core up to the outer layer. And at the same time, we can set the temperature of the core and the temperature of the outer layer. So after integrating this, we can finally comes to the relationship between the rate of the temperature increase as a function of the temperature of the core and the temperature of the external medium. And there is a standard relaxation or transferring time here. And then we solve this equation, which is a very simple solution. It's first order differential equation and non-homogeneous. And the solution is exactly the Box-Lucas model. So, and the typical heat transferring time, it depends, very interesting, it depends on the characteristics of the magnetic nanoparticle, because it depends the heat constant of the magnetic nanoparticles, it thermal conductivity of the layer, coating layer. So then we have now not a phenomenological Box-Lucas expression, but a very simple deduction of this one. So let me come to a few important conclusions about my talk. So the first one is that it is possible to preset the temperature in magnetic hyperthermia operation. You can do this just playing with the instrumentation and the characteristics of the magnet nanoparticle you are using. Because of this, it is possible to operate magnetic hyperthermia safely in the clinic. And this is because the a play in terms of material science, a play between the core characteristics and the shell characteristics in the morphology of magnet nanoparticles, a very promising approach. So for core size and shell thickness are actually demodulating parameters if you're looking at the material size. On the other hand, AC, magnetic frequency, and amplitude are also modulating parameters, which means a combination of the materials parameters and instrumentation parameters can lead you to write down clinically safe protocols for operation of magnetic hyperthermia. And finally, Box-Lucas model is no longer phenomenological. It can extract this from a basic principles of heat transferring. So I'd like again to thank the organizers of this meeting, all of you online attending my talk. And if you have any question, I will be pleased to take the questions. Or alternatively, you can contact me by using my email address. So thank you again for attending the meeting. Thanks again, the organizers of this meeting. Thank you.
Of applied nanotechnology. I am the author of nanotechnological drugs and methods of their application in clinical medicine. Let me present to your attention the first brief report on the results of the study of the effect of physiological saline solution treated with nanotechnology preparations on clinical and physiological parameters of preserved donor red blood cells during their storage in hypothermic conditions. On the relevance of this topic, if we speak in phases, 1. That can be obtained by improving the function of red blood cells of the donor at the stages of their storage justify any real or perceived inconvenience to the blood services associated with changes in blood processing procedures, the introduction of a new generation of additives. 2. Over the past 15 to 20 years, research into the development of new supplements has focused on ways to maintain higher intracellular levels of adenosine triphosphate, 3-phosphoglycerin during red blood cell storage. 3. A major challenge hindering the development of red blood cell storage modernization is the significant financial burden and risk to blood collection system manufacturers associated with licensing and implementation of a new red blood cell storage system. 4. The financial burden on technology developers of new erythrocyte storage systems is largely related to regulatory requirements. The Food and Drug Administration has recently tightened and increased the evaluation and acceptance criteria, making it potentially more difficult and costly to bring new blood component storage systems to market. 5. Technology developers do not want to take the risk that the occasional substandard blood component could jeopardize the success of licensing trials and clinical trials of their new storage systems, which would significantly increase the financial investment. The development of nanotechnology is one of the most promising ways to solve this problem. We are actively using in the clinic nanopreparations of medical significance. These are such preparations as admiral form, micromat device with bioactive properties, which is officially registered in Ukraine, magnetically controlled sorbent of MCSB brand for extracorporeal detoxification of biological fluids, officially registered in Ukraine and approved for medical practice, nanobiocorrector for intravenous application, intracorporeal nano-SORBENT of ICNB brand. These nano devices can be used as an effective means of influencing the functional activity of blood cells. Earlier comprehensive scientific studies convincingly demonstrated that these nanoparticles can inhibit hemolysis, increase the activity of adenosine triphosphate and 2,3-DIPHO-SPHOGLYCERATE in erythrocytes by 1.52 times, affect transmembrane exchange, ATPase activity, restore the bioelectric charge of erythrocyte membranes, inhibit apoptosis. We observe inhibition of hemolysis after a single treatment of heparinized blood with magnetite nanoparticles, MCSB brand. The result of hemolysis inhibition is clearly seen in a 14-day experimental storage of whole heparinized blood at a temperature of 23 to 25 degrees Celsius. In the second case, microscopic studies indicate the elimination of erythrocyte sludge syndrome in a patient with a severe degree of intoxication using the author's method of extracorporeal treatment of whole blood with magnetite nanoparticles of MCSB brand. It was found that the elimination of sludge syndrome is due to the restoration of bioelectric charge of erythrocyte membranes due to activation of reactions of anaerobic glycolysis and reaction of hexose monophosphate. The above information served as a basis for choosing the topic of the present study, devoted to the study of the possibility of using nanotechnology to correct the functional activity of erythrocytes in the stages of storage at positive temperature. The main goal of this study is to develop a simple and practical method for upgrading the preservation medium, which does not violate compliance requirements and improves the quality, efficiency, and safety of red blood cell transfusions. To solve the problem for the first time was used and developed by the author method of application of intracorporeal nanobiocorrector of ICNB brand. The basis of the intracorporeal nanobiocorrector are standardized magnetite nanoparticles obtained by chemical synthesis, though precipitation reaction. The following slide demonstrates the basic physical and chemical properties of the magnetite nanoparticles of ICNB brand used in this study. The objects of the study were preserved under erythrocytes and physiological saline solution. Before injection into erythrocytes, the physiological solution was treated with magnetite nanoparticles of ICNB brand by the Belousov method. The next slide shows the distribution of the samples under study. Studies of preserved erythrocytes were performed in 6 stages at 7-day intervals. The results of MRI studies of physiological saline solution, which was treated with magnetite nanoparticles, are shown in the following slide. Note that in the second variant, where the physiological saline solution was treated with magnetite nanoparticles, we clearly observe the effect of image brightness increase, which is caused by the increase of hydrogen protons' mobility and change of their spatial orientation. This raises a logical question. Can such an altered structure of the physiological solution affect the metabolism of the cells placed in it? This slide clearly demonstrates the effect of inhibiting hemolysis in 2 variants of the preservative, where intact saline and nanoparticle saline were added to the erythrocytes in equal proportions. Thus, The magnetic field induced by nanoparticles affects the polarization structure of the physiological saline solution. The modified saline solution added to the preserved erythrocytes changes the sensitivity of membrane receptors and affects the permeability of erythrocytes. The result of this effect is the observed effect of hemolysis inhibition. The data in the table show that on the 35th day of the study, the mean free content in the test tubes was 6.25 grams per liter lower, and the mean value of the calculated amount was 1.42% lower than in the control tubes. Indicators of sedimentation resistance of erythrocytes indicated an increase in their stability in the test compared to the control. Thus, the intermediate results obtained show that physiological saline solution retreated with magnetite nanoparticles has a membrane stabilizing effect, protects preserved donor erythrocytes from destruction, and helps to preserve the bioelectric charge of their membranes. The study of the shapes and sizes of preserved erythrocytes by direct microscopy was the next logical step in the study. Thus, in all control tubes, the appearance of spheroequinocytes on day 35 of the study was noted. On the contrary, normocytes were microscopically registered in the controls. Does the size of erythrocytes in this case depend on pH of the medium? This slide shows the dynamics of pH changes in the extracellular medium of erythrocyte storage at key stages of the study using the preserving agent CPT as an example. It was found that on day 35, stage 6 of the study, the pH in the control changed to acidic and the test to alkaline. The scheme of the simplified mechanism of the obtained results is as follows. In the first variant, as a result of an increase in the amount of deoxygenated hemoglobin, the binding of hydrogen protons from the environment surrounding the cell increases. This causes an alkalinization reaction. The second variant, on the contrary, reduction of deoxygenated hemoglobin formation and appearance of excessive amount of oxyhemoglobin in the medium as a result of hemolysis causes its acidification. Conclusions. 1. Treatment of physiological saline solution with magnetite nanoparticles of ICNB brand changes its polarization structure by increasing the mobility of hydrogen protons and changing their spatial orientation. 2. Nanotechnology modified physiological saline solution has a membrane stabilizing effect, increases the sedimentation stability of preserved erythrocytes, and inhibits hemolysis. 3. In general, the presented results of the study indicate the effect of stabilization of the functional activity of preserved erythrocytes by upgraded physiological saline solution. 4. The first optimistic results were obtained on the way of creating a simple and practical method of additive modernization of preservation solutions, which does not violate the requirements of compliance, increases the quality, efficiency, and safety of red blood cell transfusion. The results of extended biochemical studies on this topic will be presented at the next conferences. Thank you for your attention.